Hey everybody, welcome. I'm Aditya Bansod, and welcome to Digital Health on Air. Today, I'm joined by Ankit Jain, the founder and company lead at Infinitus Systems, an innovative healthcare voice AI company. Ankit brings energy, optimism, a sense of excitement, and a forward-looking approach to how technology can really evolve healthcare. We're fortunate here to have him today to join us on Digital Health on Air and share his perspectives about the new reality of AI as it applies to healthcare. Ankit, welcome to the show.
Aditya, thanks for having me. Excited for this conversation.
Good. It's going to be a blast. I'm looking forward to it too. So let's start with maybe your vantage point on AI in healthcare. You founded Infinitus in 2019. And so you clearly recognize like the need for change in healthcare, AI is an opportunity. What problems did you want to solve and kind of what did you aim to find and kind of how did you get from 2019 to today?
So right before starting Infinitus, I'd started Google's AI venture fund, Gradient Ventures, and I was investing in a number of different AI technology companies, those that were building platforms to enable the AI applications of tomorrow, which is now today.
It's not exactly.
And also a few vertical applications of AI. I'd done a few investments in healthcare, but I didn't really spend as much time in healthcare as I do now. But I showed my wife a demo of some technology that was not in healthcare to make restaurant and spa reservations.
Okay.
She listened to it. It was a phone call. You could say, "Hey, Google, make me a reservation at name your favorite spa salon or restaurant." And if Google could do it through OpenTable, it would be instantaneous. If not, the Google Assistant would call the restaurant and make the reservation. And she kind of looked at me funny and said, "This sounds like incredible technology, but is the restaurant and spa reservation really the best place where you could apply it?" And I said, "Well, that's not the point. The point is it's a machine talking like a human."
Right.
I wish someone would bring this to healthcare. And that kind of started our journey of understanding how data exchanges hands in healthcare, or fundamentally the interoperability problem in healthcare. The fact that the way processes get initiated, the data exchanges hands over phone calls and faxes, whether it's in the front office with patients or in the back office between all the different healthcare institutions, that's the fundamental problem. How do we make data proactively, transparently, and instantaneously available to everybody who needs it? We believe is a core tenet of the future of healthcare, of how we get healthcare to be proactive and instantaneous.
That's interesting. There's like a core, through that, like information is obviously the liquidity of information, I should say, is a core tenet, to use your words, of how the healthcare economy and how healthcare delivery happens. And AI, I think, is making a big part of making that more fluid, more economical, like more better matching the supply and demand to kind of abuse in economics terms. So, but AI moves super, super fast. And I'm sure, you guys have been on this journey for quite some time now. And, within 6 months, we've gone really from how health systems may use AI to how we are using AI. So kind of what's your biggest observation, let's say in the last year, as you guys have been in market and things that you've been observing from kind of going to, let's talk about it, to we're actually making it happen?
Well, the reality is we've been using different forms of AI in healthcare for quite a long time. We just call it different things. At some point, we were calling it data analysis, and then we were calling it machine learning. Now we're calling it AI. But really what it is using large language models now, whether
as opposed to like tensors or whatever it might have only been.
And I think that's what's changed. But I think there's a real excitement about what this generation of machine learning or artificial intelligence technology can do. The biggest problem in healthcare is that everyone's data exists in unstructured ways, in ways that are slightly different from entity A to entity B, or T A to
Yeah, totally.
And that's where a lot of the previous generation of technology failed, where they said, well, I can't submit the prior auth information from the provider instantaneously to the payer because the payer expects it in a different format, ask their questions in a slightly different way, and every provider has it in a different world, in a different format. And so you've got humans that play the role of translating language from domain 1 to domain 2. Now, large language models came out of Google's translation group, language translation group, and the whole tenet of it was, how do you translate tokens in language A to tokens in language B?
Yeah.
Think about the things it can unlock. It's taking data stored in one format, move it to a different format. So I think there's a lot of excitement around that ability to transform data and connect systems, where I think there's still a little bit of fear, rightfully so, is what happens when the machine is wrong? Who is blamed for it? And what are the kinds of mistakes that happen? Because for the most part, it's still very much a black box.
Yeah,
Sure.
sure.
Again, this is the same debate that's happening as self-driving cars are starting.
Right. This is not unique to healthcare, the healthcare domain, right?
Right. It's who gets blamed. When the patient says, my prior auth was denied, how do you point the finger to a person or thing or algorithm that can take the fall for it so that it's not the next New York Times headline? Because the reality is no human wants to be fired because of a mistake.
The mistake of something they didn't actually do, right?
Correct. And I think that's where, as a society, we need to figure out how we bring this technology into our fold in so many different parts of society.
So you went into a very like a really great little use case there, which is you have payers on one side, and there's 10,000 of those. You have 500,000 unique provider organizations, and the combinatorial mapping of A to B is effectively that. It's combinatorial. So that's a really great way to maybe segue into like applications of exactly what you're saying, this language to language, token to token kind of translation. So when you kind of see between payers, pharma, life sciences providers, what are the biggest applications you've seen of this kind of data liquidity or token translation, or however you want to frame the technology?
Well, if I was to break it down, I'd say it's about making the right information available to the right person in the right format. In the back office, the example of prior auth is a good one. In the front office, it's about having access to the right guardrail knowledge base when you want it, how you want it. So, my daughter was born with a very rare disease. When we were told about that, we kind of broke down emotionally. In that moment, we didn't have the capacity to think and ask all the questions. The questions we had came at 10 p.m. after the kids were asleep. And at that point, Dr. Google was
your best source of answers. Yeah.
Best source of answers. And, she was born with something called congenital hyperinsulinism. And when you Google that, you see stories of people that have a diffuse form of the disease, which you live with for the rest of your life. And you have a tube going into your stomach, and that's how you get your enzymes, and that's how you get your sugars. And we were like, oh my God, what does this mean for our daughter, for our family, for our dreams? As we talk to different healthcare providers, we learned that there's different forms. There's a diffuse form and there's a focal form. We have to go through a clinical trial to figure out which form there is. And then our daughter happened to have the focal form, which was curable, and she was cured of it. But that was a 6-week ordeal.
I can only imagine.
Where Dr. Google was our resource.
It's your best resource, yeah.
Our best resource. Now, 4 years later, you've got ChatGPT and Perplexity and all these other things, which seem to be better, and you can have them do deep research, but it's not guardrailed information from a medical perspective. But we have the opportunity to take those centers of excellence for each of these diseases, whether rare or common, and say, let's make this available to patients how they want it, when they want it, so that at 10 p.m. when you have a question, if you want to text, great, should be a text interface. If you want to call in, because that's easier and just have a conversation, then that should be the interface there as well. And so there's use cases, from start to finish. There's lots of policy questions. There's people at so many companies that are trying to figure out, how should I interpret the new policies and laws that are happening? And how do you make that available in a way that allows you to have a debate about it? And if you want to push the bounds a little bit, what are the arguments that you should make? But again, there's so many parts of healthcare delivery, healthcare policy that I think will be affected by the ability to translate from what one group has published to what the other group needs to ingest, that we can connect those dots seamlessly.
Yeah, I'm so happy to hear that your daughter is well and, cured of the focal version of that disease.
Yeah.
That's heartwarming to hear. And like going through that as a parent, I can only imagine was just incredibly challenging, difficult, sweaty late nights, trying to read between the lines and see, is this very arbitrary research paper I pulled up meaning something to our family?
Yep.
For parents in the future, 5 years from now, 10 years from now, you were actually on a panel at Vive talking about like what healthcare and AI may look like 10 years from now. So let's maybe go on that time machine for the future parents out there, for the future folks who are using Dr. Google, Dr. Perplexity, Dr. GPT. Like a year is like 5 years in healthcare. So let's start maybe the smaller time horizon. Let's go out to 10. We'll go in the time machine on this journey together. But where are we in a year? Where are we in 5 years? And where are we in 10 years? Just like, from Ankit's brain to our listeners.
So in about a year, I think a lot more administrative tasks will be handled by AI agents.
Okay.
We're going to have AI agents that are able to package up data for prior auth to submit it. We're going to have AI agents that can auto-approve prior auth. I think denials on the payer side will still be human guided because payers, again, from whether it's a PR perspective or whether
medical necessity or
medical necessity, they want to make sure that the right clinical staff is reviewing any denial because that's where all the risk is. I think as we move forward a few years, we're going to see in the healthcare IT world a proliferation of different kinds of AI agents in the front office and the back office, and the healthcare IT teams will go, we didn't predict that we are going to be AI agent integration factories, and how do we pass data from AI agent 1 to AI agent 2? Today, if you think about your workforce, you've got a workforce of human agents, and over time, hundreds if not thousands of startups and large companies are going to come up with point solutions of AI agents. The first 5, 10 people will excitedly go and implement, but then they'll realize, well, our humans were connecting step 1 in the workflow to step 2. So what is the equivalent of that in the next couple of years from a connecting step 1 to step 2, where step 1 might be done by an AI agent, step 2 by a human agent, step 3 by an AI
agent. Yeah, or some unknown combination of those as we continue, right?
Exactly. Because the healthcare workflows, every entity has their own ones. It's not standardized across the ecosystem.
Oh, of course not. Yeah.
What we're going to need as an ecosystem is a coordination layer, an operating system, whatever you call it, that brings together the workforce of the future, which is human agents and AI agents working side by side. And just like we had in the, this takes me back to the time I spent in the early days of the Android team. When we developed a mobile OS, we developed interfaces between apps so that when you click inside X and it opens the browser, it can have a deep link which has context. And if you click back, it takes you back there. So what is that operating system for these AI agents to pass context from agent A to agent B? And then once a task is done, go back to the original agent or move forward. And I think a lot of that innovation research discussion is happening in the industry, in the back. And it was nice to start hearing some of that at Vive. But going forward, I think in the 3-year timeframe, we're going to need something like that in order to enable the system to, the entire healthcare system, to start taking in the number of AI agents that are going to be proliferating. And it's
question for you. In that world where you're there's this orchestration layer, operating system sitting on top of both agentic and human kind of workflows and the connectivity between them, is anything that healthcare specific? Or is it kind of like a problem we may have across how AI is deployed into lines of businesses, regardless of industry?
So I think we're going to need to solve it at 2 layers. I think there's going to be basic building blocks that happen in a industry agnostic way, absolutely needed. But there are certain kinds of context that when they pass data from agent A to agent B that are so healthcare specific, you don't want every agent developer to have to rethink it because the underlying operating system doesn't give you those primitives. It's the same way where Salesforce had Sales Cloud, then built a few modules to build Service Cloud, a few modules to Health Cloud, and then Life Sciences Cloud. The difference in all those clouds is the definitions of data modules that can then be shared.
Sure.
System. So I think the same thing is going to happen with industry-specific OSs on top of maybe an open source OS that does this kind of coordination or orchestration across human and AI agents.
So there's I think that's an incredibly valuable insight, for our listeners and for the industry writ large. Core fundamental technologies around agentic workflows and human-oriented workflows are going to have to be developed, regardless of an auto manufacturing or sales or whatever it might be. But then vertical domain-specific kind of problem sets kind of need to be done for those specific ontologies. I think it makes a ton of sense too. So if you're thinking about the next, handful of years, you're talking about you covered a couple different groups there, which is there's the operational side, there's the clinical side, there's prior auth. Where do you see the path of adoption happening the fastest? And where do you think we might see the adoption get deepest first?
Yeah, I think very transactional flows will happen first because
makes sense.
There's very clear definition of input and output for these AI agents. I think the more open-ended workflows that happen today that are powered by humans, where we're exploring things or we're trying to figure out what questions to be asked, I think there will be some folks that dip their toes in those directions, but for the most part, that's where the risk is as well, because it's open-ended. And I think but I do think in the next 2 to 4 years, we will start seeing adoption of that. As soon as you start seeing where there is success, others will follow, but we're still not crossing the chasm on that piece. I think we are crossing the chasm on the more transactional administrative.
Is that sort of why you kind of gave the prior auth as the example there probably a couple of times? It is sort of like package of data, yes or no, and then denial goes into the other bucket.
Exactly.
Makes sense. And hesitancy, like, you guys, Infinitus, you're kind of operating, you're living in this space. What are the hesitancies you're seeing right now, or things that you're like starting to get the feeling on those hesitancies might be starting to crumble away?
Well, I think one of the things that we had predicted, but not so fast, is how it's going to get to develop a demo. And that is causing a lot of heartburn for a lot of buyers, because when a health system IT leader says, I want to take on a scheduling bot, or I want to take on an AI agent in voice to answer questions about pre-colonoscopy prep, you can build a demo in a week.
Sure.
Building blocks already exist. So, in a traditional world, you do an RFP, you get a bunch of vendors in. The procurement is very proud of the fact that they could get 10 vendors that will come in and give you pricing and give you a demo. But it was very hard to build demos a couple of years ago. So only the companies that had something real were able to make it to that step and actually get the checkbox. Well, I think it's gotten incredibly easy to build a demo. And a lot of pressure on the group that is deciding which vendor to move forward with, because if they choose the wrong one, that's a couple of years wasted. That's
sunk cost.
Sunk cost of their teams, of their time, of their resources, and ultimately not value added to their patient populations. And I think that's something that some groups that are at the bleeding edge are starting to realize, and they're starting to ask questions like, well, what's your viewpoint on how we should test this technology so that we can test it before we even make a decision, which I think is really good for the ecosystem. It's the way, right? But we have to make it easy for people to test or pilot.
I mean, it's like you don't buy a car on faith alone, right? You get in the car, you push the pedals, you see where it goes.
But traditionally, that's not how technology.
Yeah, in RFP bidding processes, you're like, boxes check, vendor score evaluation, good luck, start negotiating.
Correct. And I think we are getting to the point where there will be some people that are burned that will eventually get everyone to go, we have to try before we buy. Just like you go for a test drive of a car, you will want to go for and test out AI agent platforms or specific AI agents and see success, or you will just go to the safe vendor, the ones that have a reputation. So it's going to lead to a lot more consolidation in the industry as well. One thing for the listeners that I'll put out there, like I often tell folks, the best way to test a voice AI agent is to do the same task 10 times in a row. The first it might work perfectly the first time, but when you do it 10 times, the chance of hallucination,
see what the temperature is, right? Like, and see if it's the same or different. It's a great piece of advice for a buyer.
Yeah. And I don't think enough people do it. Everyone just tests it once and goes, oh, that was great. I'm like, nope, test it 10 times. And, even if it's right 10 times, try to understand why it was different the 10 times, because that will tell you how the underlying technology is built.
So maybe this leads to one question you're going to round out with today, which is, Keith Friedenberg at Chime was kind of observing a podcast that smaller and more rural and community systems maybe could actually use AI the most. And a lot of times these organizations, have this challenge where they actually just have to rely on the voice of the vendor, right? They're not like these large IDNs or whatever it is who have the opportunity, the expertise to like try 10 times to have a proper procurement team and that sort of stuff. So, in the world of AI, and talking a little bit about, because like you said, demos are so easy, the technology is democratized, right? So on the other side, on the buyer's side, like what words of advice might you have for kind of the buyers of AI technology, not just from the big IDNs and the larger health systems, the larger payers, but also to the smaller side of the ecosystem as well?
This might not be self-serving, but I think the community hospitals have a lot of leverage in today's market because there's so many vendors who are all looking for legitimacy. And they have the ability to say, I've not got big budgets, but I will partner with you and help you build your business. And so you can find those early hungry partners to go try things out with very little financial risk. You still have the risk of time, but I think there's enough signals to be able to gauge whether a company will be there, be a good partner as you iterate. But I would actually push some of those community health systems to try to be even more at the cutting edge than they have been. And it was their differentiator, which is the fact that they can move fast, the fact that they can test things out and be a partner to early innovation, which is something that the large IDNs aren't able to do. They have processes. And so everyone has to lean in on their strengths. But I think that's the strength that the smaller rural and community health systems have.
I love it, because I think, where they may not have the technical expertise, what they do have is exactly, you said, the ability to borrow a phrase, to move things and move fast and break things.
Yes, exactly.
So let's look ahead, kind of closing thoughts. We're in 2025. From Ankit's brain, what does the world look like? What are you optimistic about? Like, what's exciting 2 years from now if we're doing another episode here in a couple of years?
Well, in 2025, we're right here.
Oh, sorry, 2027. My bad. 2025.
So 2027, I think we're going to have a lot more comfort around how to evaluate this kind of technology. We're going to have more consolidation in the market, so a few winners rather than hundreds, if not thousands of vendors all saying AI. I don't think we're going to be using the term AI. I think we're going to be focusing on the specific problems that AI is not going to be sexy anymore. Just like RPA isn't sexy anymore. It's
funny enough. Like I was like this year at Bob, I'm like, are we done calling it AI? It's just like it's been 3 years now. So
exactly. So that's my second one. But the third one is I think we're going to start hearing real stories of how the patient experience is getting better. We're going to hear about how patients feel like they're more heard, that the system has more time for them. The optimist in me believes that AI can give patients the gift of time. When we get that call from a nurse or a provider, as helpful and empathetic as they want to be, they're thinking about the next patient they need to call.
Yes.
Hear that in their voice. And I think AI agents have the ability to give that gift of time that we unfortunately don't have as a system today.
I love that. Ankit, that was incredible. And, I think what a wonderful way to wrap up that the most precious gift is the gift of time, whether it's with, your patients, your loved ones, your families, whatever it might be. So I thank you so much for spending some time with us today on Digital Health on Air, sharing some really incredible insights ranging from policy to the future mapping of the ecosystem, to even understanding what it might mean for when healthcare deploys AI broadly, and actually how to orchestrate it as we deploy more and more agents across the healthcare delivery universe. Ankit, it's been a pleasure to have you on Digital Health on Air today. Thanks so much for your time.
Thanks for having me.